Thank you for the introduction. Good afternoon, everyone. As you will realise, I am Mary Prescott.
And I'm Richard Lawson. We've worked together in nuclear medicine in Manchester for 40 years.
And before anyone worries about our COVID risk, we have been bubbling along together since we married 47 years ago. But apart from that relationship, we have nothing to declare. When BNMS asked us to give the highlights lectures, we were honoured, but also somewhat daunted. Usually the highlights speaker has a very hectic meeting, rushing around between sessions and preparing slides in the evening in their hotel room. But in fact, this virtual meeting has been very different. We've had the opportunity to view all the presentations instead of having to pick some solely from abstracts. But we have missed the ability to listen to the discussions after the oral presentations and to hear other people's opinions, particularly in fields which are not our particular expertise.
The 2021 meeting has been entirely virtual, so I suppose the venue is represented by the cloud. We've had 3 days with 3 parallel streams, 50 oral presentations, 40 posters and 58 invited talks, not to mention the annual lecture and a virtual commercial exhibition. So that amounted to more than 40 hours of viewing time. But remember, that is still viewable for the next month. So if we recommend something that you missed, you can always go back and look at it later. But we have enjoyed attending many BNMS meetings together over the last 40 years, so we thought it would be interesting to see how this meeting compares with previous meetings. The first meeting that we attended together was 1977 in London, in the University of London Students' Union. There were 2 days, no parallel sessions, 34 oral presentations, 14 of which were from London, 18 posters, no invited reviews that year, and the annual lecture was on the exciting topic of computerized imaging. And of course, that's been brought entirely up to date this year with a lecture on artificial intelligence. There was a small commercial exhibition, and I made my first contribution of many to nuclear medicine meetings with a poster on probrinography. And we note that from the programme, BNS membership that year was a princely sum of £2 a year. In 1978, the meeting moved to a larger venue in Imperial College because it was a joint meeting with the European Society of Nuclear Medicine. There were 3 days with 69 presentations, 37 posters and some technologist teaching sessions. And the annual lecture was on nuclear cardiology, an up-and-coming topic, which this year is included in 9 presentations, so that's still going strong. There was a significant commercial exhibition and an exciting social event in the Cunard Hotel. There followed a series of meetings at Imperial College, and in 1982, for example, there were 2 parallel sessions and invited reviews for the first time. There were lots of cardiac and renal papers, those dominated the programme, and the annual lecture was on the novel technique of magnetic resonance imaging, which of course this year is also mentioned in 3 presentations.
There were 17 meetings in Imperial College between 1978 and 1995. Student accommodation was very basic but convenient, but the exhibition space was very limited. So in 1996, the venue moved to Brighton and there followed 10 meetings there. Brighton offered a larger space for the commercial exhibition and included interactive talks for the first time. There was a civic reception and a social event at the racecourse one year. In 2001, we had a busy programme with 4 parallel sessions. The annual lecture was on PET, which was very new then, but then this year was included in 23 presentations. BNMS membership was now £95, but that did include a subscription to Nuclear Medicine Communications. The first meeting in Manchester was 2002, and we returned there for 6 meetings. It had all modern conference centre facilities, but was expensive. It had a large exhibition space, comfortable lecture rooms, and the usual social functions. 2003 was a typical meeting in Manchester, 3 days with 4 parallel sessions. The annual lecture was on the benefit of combining hybrid PET with CT. Of course, in 2021, this is now routine, and all PET presentations assume CT as well.
The first meeting at the ICC in Birmingham was in 2016, and there followed 3 more annual meetings there. In 2016, there were even more invited reviews and a very large commercial exhibition. And in 2019, the meeting moved to Oxford. This was a much smaller venue, but it still included lots of varied talks. There was a smaller exhibition, but an excellent conference dinner in one of the colleges.
So that brings us back to 2021, and Richard will start with some of this year's highlights.
There were several interesting presentations under the heading of radiation protection. Boot camp session 4 on Monday morning was all about practical dose calculations for risk assessment. And these two invited presentations gave good practical advice on how to perform calculations relevant to determining whether staff may need to be classified after a foreseeable accident. Bill Thompson from Birmingham talked about an introduction to skin dysymmetry, contamination and needle stick injuries. And Matthew Mehmet from Manchester gave a talk on external dysymmetry, eye contamination, and an overview of commonly used calculation techniques. So if this is your area of interest, I can recommend both talks if you want to go back and look at them. But in fact, both authors also had related oral presentations, so I'll show you a flavour of those. As usual, Bill Thompson gave a very practical and useful talk on the potential dose to the hands from accidental contamination. His presentation, which was oral 45, was well deserving of the second place for the oral prize. He modelled possible contamination in the radiopharmacy from a small droplet a few millimetres across, and he compared the possible dose to the skin with no gloves with that using gloves. And he showed that using gloves for technetium-99m reduced the dose down to a very small fraction. There was a moderate reduction for fluorine-18, but only a small reduction for yttrium-90. Of course, the gloves can easily be removed. So if you remove the gloves after, say, 1 minute, he showed that there was a moderate dose to the skin from technetium-99m, but quite a high dose from yttrium-90, which exceeds the non-classified limit. He also showed figures for vinyl gloves, which are thinner and so give less protection, and also similar results for contamination over a larger area, such as you might get during injecting or drawing up. So in Birmingham, they have now changed from wearing simple apron for drawing up and injecting to an apron that covers the sleeves so as not to expose any skin, and even face shield to avoid any skin contamination. Oral 46 was Matt Mehmet from my old department in Manchester, presenting his work on estimation of the equivalent dose to the sensitive epithelial layer of the lens of the eye after contamination with common radionuclides. He had data from the literature for residence times of fluid in 3 compartments, the cornea, the lacrimal lake and the drainage apparatus, and he used published data for dose rate kernels from point sources and applied that to his 3 sources to calculate the dose to a target of the lens of the eye and integrated over time to get the absorbed dose. So for fluorine-18 and gallium-68, he showed that a significant splash into the eye could give a significant dose, although that was halved if you mitigated it by washing the eye within 2 minutes. However, for yttrium-90, the dose is greater and it's still above the limit for classification after washing within 2 minutes. So he concluded that for diagnostic radionuclides, there's no need to classify staff, but using PET radiopharmaceuticals may need classification, and using yttrium-90 will require classification from a foreseeable accident. So I also like this presentation, Oral 47 by Alex Smout from Guildford, on simplifying committed dose calculations for comforters and carers. Of course, IRMA requires that we give a good explanation of risk to comforters and carers, but the dose depends on individual circumstances, so it's not easy to do a personal calculation quickly. However, the literature gives the dose rate at 1 meter from a patient and the effective half-life. So it's easy to calculate doses like this that Alex did for his patients, giving the committed dose to someone who stands at 1 meter from the patient 24 hours a day. And Alex called that the committed dose per K, where K is a contact factor. So for a parent who might well spend 1 meter away from the child, K would be 1, and this would be their committed dose. But if you envisage a family member who spent less time close to the patient, K might be estimated to be 0.5, so you would halve these figures. But you can also envisage a carer who spent some time closer than 1 meter, so you could estimate, say, a K of 2, which means you would double these figures. So for any particular family situation, you could estimate a contact factor K and give an estimate of the committed dose, and I rather like that method. There were 2 physics presentations that particularly interested me. Oral 43 was a presentation by Ruby Callister as part of her MSc project at the Royal Marsden Hospital on errors arising from S values for the dosimetry of paediatric radionuclide therapies with iodine-131 and lutetium-177. I thought this was a very nice piece of work, and it deservedly got the Lee Jenkins Memorial Prize. She calculated absorbed dose as cumulated activity multiplied by an S factor, but the S factor depends very much on the age of the child. So she looked at different ways to calculate these S factors and compared the error in the S factor with the error that's due to the inherent uncertainty in organ masses, which you never know precisely anyway. Her gold standard was the S factor derived from organ sizes from the CT data for the actual patients and using a Monte Carlo simulation based on those actual organ sizes. So she compared that with the other techniques. So on this graph, she gives the dose to the liver, kidneys and tumour, and in each case the red dot here is the gold standard from her Monte Carlo with real patient sizes, and the dotted lines show the uncertainty due to not knowing the organ masses precisely. The figure in blue here from Olinda is using the standard size child phantoms, and that's a little bit low, but she showed that by including mass scaling, which adjusts for the actual size of the child, it improves it so it's within these expected errors due to organ mass. And she also showed that there was hardly any difference between these 2 figures here, whether or not you include the contribution of dose from other organs. These were the results for iodine-131 Mibg. She had similar results for lutetium-177. So her recommendations were that reference phantom-based S values with mass scaling applied are adequate for paediatric dosimetry calculations, and consideration of organ self-dose is sufficiently accurate and much simplifies the organ dose calculation. Now, oral 15 was this MSc project by Sarah Williams from Glasgow Royal Infirmary on development of cardiac phantom for dynamic imaging. It caught my attention because it brought back memories for me of supervising similar projects in the past, so I have respect for what she's achieved. She produced this prototype with 3 syringes that could pump activity in and out of the 2 ventricles. She got it moving so that you can see that it's able to pump up and down and put the activity into the phantom here with the 2 ventricles pulsating quite nicely. And she was even able to obtain some images with it. So well done to her.
It was good to see that there is still interest among students for nuclear medicine projects. One submission was even work done in a work experience attachment. The oral presentation from students won the prizes on the basis of their submitted abstracts, but all were nicely presented. The 3rd student prize went to 2 students from Guy's and St Thomas's Hospital. They used GE's QClear software to reconstruct gallium dotatate images of neuroendocrine tumours. This is not a new concept, but was a nice demonstration of it. They concluded that QClear improved the signal-to-noise ratio, but it also increased the SUV max in the lesion. As we know, that can lead to difficulties if you're trying to compare patients scanned with different systems. But they concluded that this was an accurate and reliable method of analysis. The 2nd student prize went to Marie Kershaw from Birmingham. She looked at patients who had pre-surgical assessment for their temporal lobe epilepsy using FDG PET and CT and MRI. She used GE's Cortex ID software, which uses statistical parametric mapping to get a Z-score. She concluded that its use could improve consistency in image reporting, but that further work was needed. The first student prize went to Miriam Hussein, a medical student from Southampton. She looked at paediatric gastric emptying studies and the presenting clinical problems in the children at time of referral to see if any could possibly be a predictor of delayed gastric emptying. She concluded that chronic vomiting or reflux in children associated with a genetic abnormality was the only significant single factor associated with delayed gastric emptying. There were a few radiopharmacy presentations that I would like to mention. On the Monday afternoon session 4 in radiopharmacy, Neil Hartman and Louise Fraser gave an invited talk about the UKRG Nuclear Medicine Safe Drawing Up Guidance and the RSAC requirements. The UK Radiopharmacy Group have drawn up guidance on how to draw up patient doses. This states that you need a Grade A environment for drawing up doses. There has long been debate about this, but it has now become accepted guidance. And whilst this is just guidance from the UKRG, RSAC have now noted it, and in their information on applying for an employer's certificate state, in terms of drawing up, it is expected full compliance with UKRG guidance, if not, a proper up-to-date risk assessment which includes a date when compliance with the UKRG guidelines would be envisaged, so effectively that makes it mandatory. The Radiopharmacy Prize went to George Firth from King's College on approaches of PET metallomics for the study of metal trafficking in vivo. This was an interesting piece of preclinical work looking at the use of zinc 62, copper 64 and manganese 52 in tracking these metals, which can have abnormal kinetics in some disease states, for example Wilson's disease and cancer. In summary, he found that despite its complex decay, 62 zinc can be a useful option to study zinc trafficking and can be used for up to 48 hours. The ionic form of copper has little effect on its biodistribution, but serum binding does slow down blood kinetics. And 52 manganese can be used to study trafficking for up to 4 weeks. I was very interested in this presentation, investigating the use of sporicidal disinfection step during the preparation of pharmaceuticals with technetium from my old department in Manchester. This work was done by an STP trainee who has now moved on, so it was presented by Shazmeen Hansrod. This has long been a topic of debate, as although spore-forming organisms are a concern, there was a reluctance to use sporicide due to the potential oxidizing effect if it reaches the product. So they did a survey of radiopharmacies and found only 36% used a sporicidal agent. Following this, they did extensive tests in their own department and found that there can be detectable traces of sporicidal residue on the vial bung and critical components after application. However, the subsequent transfer and disinfectant spray wipe steps can be effective in removing the trace quantities of this residue. No radiochemical purity testing failures were observed when a sporicide was used as part of the transfer disinfection process, so that is really good news. It seems it can be used. There were multiple presentations, invited reviews and masterclasses in endocrinology and neuroendocrinology, both diagnostic and therapy presentations. It is really good to see that neuroendocrine has now definitely moved from niche to be firmly mainstream with 2 bootcamp sessions. Parathyroid protocols and how to do them are still topical. Session 10 had a masterclass with Richard Graham discussing SPECT-CT and Dražen Huic talking about F-choline. In the proffered papers, Dr. Ilias from Guy's and St Thomas's threw another variation into the mix with surface rendering, which she found helpful in very difficult cases. She reviewed 51 patients and concluded that her protocol of dual SPECT with surface rendering is extremely effective in correctly localizing parathyroid adenomas with a success rate of 92% of cases, which compared very favorably with the literature. Looking at the data in a different order, 98% of parathyroid lesions were localized only in early images, using only early images, and is 100% effective in patients with good thyroid protectate uptake. She was proposing switching to SPECT CT on early SPECT and evaluating again to see whether the late Mibg can be dropped. In neurology, Rob Foley from Bath gave this talk on the analysis of cardiac Mibg scintigraphy in Lewy body disorders. This was new to them, and they were very carefully auditing their performance as they went along when they noticed that their heart to mediastinal ratios were increasing the disagreement of interpretations of the reports, and all values were below the expected level, irrespective of what the images showed. They assumed this was due to variability in drawing regions, but on investigation, this was not the case. They realized that the values had been set with medium energy collimators, and they were using low energy. I123 strikes again. The planar images can look fine, but quantification is very different. A timely reminder to us that the devil may be in the detail, and having rectified the issue, they did actually find that the technique was useful in Lewy body disease.
I just want to mention one scientific talk in the area of PET. This talk, Oral 12 from Chris Matthews in my old department in Manchester, got the Multimodality Prize. Unfortunately, his punning title, which was Looking at FDG PET with 2020 Vision, was slightly spoiled by the fact that this meeting was delayed until 2021, but nevertheless it deserved the prize. The department has had a new Siemens Biograph Vision PET CT installed in October 2018. It's got solid state detectors which give better sensitivity and better timing resolution. So his talk was a reflection of their experiences in optimizing their protocols for this new scanner. For the first year, they used standard time of flight reconstruction, but in 2020, they changed to using the Siemens UHD reconstruction, which includes point spread function modeling in the reconstruction. They were able to use faster scans. In fact, they reduced their scan time by 17%. They retained quantification. In fact, the SUV value didn't change, which is good. They got improved image quality with a better signal-to-noise ratio. And importantly, the signal-to-noise ratio didn't depend on patient size. So they seem very happy with the UHD reconstruction. As always, there were some really practical presentations in the radiographers, technologists and nurses sessions. In the RTM bootcamp session on Monday morning, there were two talks on advanced practice. The first one was on leading stress testing by Mark McDade from Glasgow Royal Infirmary. He gave lots of good advice, and I would recommend this talk for anyone involved in leading stress testing. The second talk in this session was from Luisa Rodeo Pereira from Maidstone on advanced clinical practice in radionuclide therapies. She explained what you need to know about becoming an advanced clinical practitioner, with particular reference to radionuclide therapy, which was her specialty, but a lot of what she said was also relevant to other areas of nuclear medicine. Another RTN session on Tuesday morning was on implementing new technologies. In there, Philippa Alves and Cindy Slabbert, two very enthusiastic technologists from Birmingham, talked about their new Veriton Czt Camera. This is the Veriton camera. It's an unconventional design. It has 12 individual detectors all the way around the patient, which can independently move in and out so that they can all remain very close to the patient, and the whole thing can rotate around the patient as well. So the advantages of this camera include better energy resolution because it's got solid state detectors. It can get closer to the patient, so it gets better spatial resolution as well. It can use organ-specific detector focus, and you can have either reduced patient dose or reduced scan time because of its better sensitivity. They liked the fact that they didn't need to change any collimators, although one consequence of that is it's only suitable for low energy radionuclides. So they were able to get bone scans in half the time, here 3.5 minutes per bed position instead of 7 minutes. They asked patients what they thought about the camera, and very importantly, no patients refused to have the scan. Most said that there were no problems at all, and only a few down here felt that they were uncomfortable when the camera came very close and touched them. So they seemed very pleased with their new camera. Mark McDade also gave a nice oral presentation on which got the RTN Oral Prize. His title was Regadenoson Rescue of Failing Physiological Stress, an Evolving Safety Profile. In patients who were failing to reach target heart rate under exercise, they proceeded straight to give regadenoson without waiting for a cooling down period. They found that this was safe, and in fact their serious event rate was less than their previous experience with dipyrimidiol and dobutamine. And they found it safe in patients with COPD or asthma, and they demonstrated a statistically significant relationship between work done and scan quality. So rescuing a failing exercise test maintained a good quality scan. I would like to highlight a couple of talks on non-imaging investigations that caught my attention. Oral 20 by Gillian Ainsley McLaren, a physicist from Glasgow, was about red blood cell volume measurement. Can indium replace chromium? This was awarded first place prize for the oral prize, and it's relevant because, of course, we can no longer get chromium-51. In Glasgow, they use a dual isotope technique. Stage 1 involves measuring plasma volume using I125 labeled HSA. That deduces the red volume from the hematocrit and the plasma volume. In stage 2, they measure the red cell volume directly, originally using chromium-51 labeled red cells and now using indium-111 labeled red cells. These graphs show Bland-Altman plots with, on the vertical axis, the difference between the red cell volume measured from the red cell label directly and deduced from the plasma volume against the red cell volume. On the left is the results using their new technique with indium-111. On the right, previous results using the old technique with chromium-51. So although these are different groups of patients, they showed a similar distribution. So she concluded that indium-111 is a good alternative to chromium-51. It does need some changes to procedures, but that does seem to be good news. We can still do red cell volume tests despite not having access to chromium-51 anymore. I also like this presentation, Oral 7 by Alex Smout from Guildford. Can patient age be used to determine the optimum GFR single sample time? As you'll be aware, the latest BNMS guidelines recommend taking a single sample for GFR, either at 2, 3, 4 or 6 hours, depending on the expected GFR. But Alex pointed out that it can be quite troublesome to get a current GFR estimation. However, GFR falls with age, as you can see here, so he wondered whether age could be used to determine optimum sample time instead. So they have samples at 2, 3 and 4 hours, so they can calculate the correct slope intercept GFR from all samples and compare that with the single sample estimate taken at different times. So this graph shows on the vertical axis the sum squared error, the difference between the true measurement and the single sample measurement plotted against the GFR. So you can see at low GFR down here, the green gives the lowest error, which is a 4-hour sample, and at high GFR, the blue, which is a 2-hour, gives the lowest error, and that agrees with BNMS recommendations. But this blue line is the result using a sample taken at their time just deduced from the patient age, and you can see that over most of the range, it's nearly as good as the optimum one. So he recommended that the best method is to use the EGFR to inform the sample time as per the BNMS guidelines, although that can be quite labour intensive in trying to get that result and for booking and scheduling. So the second best method is their suggestion of a 2-hour sample for all patients aged less than 60 and a 4-hour sample for patients aged over 60, which is very easy for booking and scheduling and only gives us slightly higher errors than the optimum time. The third best method would be to use a 4-hour sample for everybody. There was a session on Monday for the Young Investigators Prize. The prize went to Gerard McKieran, a clinical technologist from Belfast, for his presentation on the optimum timing of the CCAT test in the diagnosis of bile acid malabsorption for patients with chronic diarrhea. He did an audit of their CCAT studies, looking at when they were performed in the patient pathway. He aimed to determine if CCAT could be performed earlier and whether this would affect the result obtained. On the left, you can see 82 patients who had an invasive procedure such as colonoscopy, sigmoidoscopy or endoscopy before the CCAT test. And in that group, 52% had no bile acid malabsorption, 14.6% severe, 18.2% moderate, and 14.6% mild. On the right, you can see 124 patients who had didn't have the more invasive procedures before their CCAT. And you can see the distribution is very similar. In fact, he did a nice statistical analysis and found no difference between these two distributions. So he concluded that CCAT tests could be performed earlier in the diagnostic pathway without compromising the result. He thought that could lead to an earlier diagnosis and improve the quality of life for some patients. Artificial intelligence is obviously relatively new in nuclear medicine, but it's clearly going to become more important in the future. So there was a session devoted to this on Monday afternoon. Pieter Slomka from Cedars-Sinai Medical Center in Los Angeles gave an excellent review of the current status of clinical applications of AI algorithms in nuclear cardiology. And he explained how AI can be used to enhance existing images, which can allow the possibility of imaging with lower doses. It can even be used to apply attenuation correction without any CT images, and it can outperform current measures for predicting revascularization and further disease. And it gives enhanced prognosis for patients by combining clinical and image information. Then, of course, on Tuesday afternoon, we had the BNMS annual lecture by Arturo Citti from Milan on artificial intelligence and radiomics in oncologic imaging. He distinguished between radiomics and artificial intelligence as two methods of getting prognostic predictions from medical images. He didn't cover the sort of applications of AI processing that produced images that Professor Slomka had talked about in nuclear cardiology. In radiomics, he explained that you first have to segment the image into to extract the features such as tumor intensity, tumor shape, and tumor texture. Then analysis modeling combined with clinical data gives the results that you want. On the other hand, he said that artificial intelligence employing deep learning typically uses different sorts of neural network to process the images automatically. These are described in his recent paper in Clinical and Transitional Imaging. I was interested in this figure that he showed from a recent publication in European Radiology, which shows that there are now 100 commercially available AI products in radiology. However, most of them only have a modest level of efficacy, and in fact, most are here for CT and MR and X-ray, but apparently none for nuclear medicine. So he ended by calling for authors to strive for the highest possible scientific rigor, to follow dedicated checklists and obtain higher evidence levels. And he hoped that design of prospective multi-center randomized controlled trials with data sharing will prove the clinical usefulness and improve patient outcomes.
I would like to highlight one thing in another Prof paper on PET. This was another presentation from Rob Foley of Bath on their initial experience with F18 PSMA PET-CT. Part of the presentation identified that the tracer they were using, PSMA 1007, was excreted via the liver in comparison to the other forms which were excreted in the urine. The lack of ureteric and bladder activity allowed improved interpretation for local recurrence of CA prostate and periureteric nodes, which was yet another example of the need to know the detail, as variations can make a big difference. He identified the pitfalls with uptake in ganglia and other tumours, as although most associated with prostate, it is not completely prostate specific. Molecular radiotherapy was well covered in the meeting, and PSMA is now the hot topic. Most of the work on PSMA therapy is with lutetium-177, but that is not the only radioisotope available for therapy. This interesting talk by Dr. Mark Satheki contained lots of the background and issues in treating prostate cancer and the role of radioligand therapy and the various aspects that were considered before choosing the alpha-emitting 225 actinium as the label attached to PSMA 617. He also covered many other aspects, including side effects and their potential mitigation and the interaction with and relation to other therapies. There have been some very promising results in clinical trials with actinium-225 PSMA using 100 kilobecquerels per kilogram, which appears to have good efficacy with relatively little toxicity to the salivary glands. And there have been some excellent long-term results with median overall survival of 18 months, with longer terms of 3 to 5 years in some patients. There were prizes for oral presentations in radiotherapy, and the third prize went to Adrian Ho from Southampton for his audit on their 223 radium therapy for bone metastatic castrate-resistant prostate cancer. He concluded that using radium-223 earlier in the treatment pathway improved overall median survival by an additional 98 days. And he recommended further research as the optimal sequence of the treatment pathway appears to have changed with the time. The radiotherapy second prize went to Alison Craig from the Royal Marsden for her work on the uncertainty calculations for 90 yttrium cert absorbed doses based on the EANM guidance. She looked at 16 patients who had had Y90 cert therapy and used the EANM guidance to calculate the uncertainty on absorbed dose to normal liver and to the tumour. She concluded that calculation of the uncertainties in Y90 cert absorbed doses is feasible, and that the uncertainties in normal liver absorbed dose estimation can be reduced by more accurate measurement of the Y90 activity. The radiotherapy first prize went to Hajira Ilyas from Guy's and St Thomas's Hospital for her review of patients who had had lutetium dotadate therapy for neuroendocrine tumours with respect to their HbA1c levels, which can be affected by the disease and by the steroids used to treat the edema and associated with therapy. She looked at 119 patients and concluded that there is an increased incidence of elevation of HbA1c in NET patients having dototherapy. Of those, 75% were not known to have had diabetes mellitus or an impaired glucose tolerance test, reaffirming the need to do HbA1c pre-assessment analysis. Finally, in radiotherapy, John Buscombe reported on the findings of a joint report on the present and future position of molecular radiotherapy in the UK. He aptly described radionuclide therapy as a Cinderella aspect of the field, and there is the perception of a postcode lottery. And he indicated a potential big increase in the requirements for therapy services with lutetium PMSA. They did a survey last year which showed great variation, and clearly the situation is not good. There is still a significant postcode lottery. So they did a follow-up survey for the centres that were interested in doing more therapy or indeed starting a service. Probably less than 20 are really ready to treat with PSMA, and more training is needed, and dosimetry issues may require support of a centralised dosimetry lab. And just to scare us further, with the overwhelming workload, John left us with these facts. 19 new molecular radiotherapy agents in company-sponsored trials with the FDA and the EMA approval at the moment, and Major Pharma has invested $6 billion in these products in 2020 alone. We may want to ignore it, but it is not going away. But in my mind is, where is the UK funding going to come from? In Hot Topics, there was a talk by Sue Mitchell from NHS England and NHS Improvement about PET-CT services. It appears that the PET service commissioning is undergoing yet another reorganisation. This talk explained some of the changes, but did confirm that NHS England would keep responsibility for national standards and service specifications. The talk also contained information about the current work programme being undertaken with regard to PET-CT. Finally, whilst this preclinical work may not be for everyone, this talk given by Dr. Southworth was an excellent and fascinating insight into the efforts of those at the very beginning of tracer development and in advancing the understanding of the physiology involved in disease processes. His work focused on PET and SPECT-CT in cardiology, with the aims of diagnosing disease earlier beyond the limits of current structural and functional imaging, and provide new mechanistic insight into the disease processes. He identified these imaging targets and the tracers that could potentially be used, and showed examples of hypoxic conditions which included Syndrome X, thought to be coronary microvascular disease, radiotherapy damage, and cardiac hypertrophy and diabetic cardiomyopathy. He included data showing the effect of hypoxia on retention of the old dog, Mibg, in the cells. This work opens up the possibility of identifying early cardiotoxicity with chemotherapeutic drugs and in cardiomyopathies with a view to intervention before there are irreversible functional changes. So we hope that you found something of interest amongst our highlights, or from the highlights of the posters that were covered by Stuart Redman earlier.
Remember, everything is still available on this event platform for the next month. So if you're an individual, you just need to log in again. But if you're attending through a hub, you'll need to use an individual login to see the oral presentations and the posters, but the group login to see the invited talks.
We've missed being able to meet colleagues in person, but we have enjoyed the presentations.
And the queue for lunch was short, even though we had to make it ourselves.
And clearly, despite all the current challenges, it's good to know that nuclear medicine continues to develop.
So thank you for listening to our highlights.